45 minutes, and then we'll have time for Q&A toward the end of the hour. You can ask questions to our speaker directly following the talk, or type your questions in the chat at any time during the talk, and at the end, I will bring those questions to the speaker. So now I'm most pleased to introduce our speaker today. Dr. Lillie Williamson is an assistant professor in the Department of Communication Arts at the University of Wisconsin at Madison. Dr. Williamson's research broadly examines the ways in which racial experiences and health communication interact to influence health inequalities. Much of her work investigates the effects and interactions of communication within and outside the clinical context and medical mistrust, particularly for Black Americans. She approaches this work grounded in 3 principles. Medical mistrust as an adaptive response. Her work is useless if it is not rooted in and reflective of lived experiences. And given the pervasiveness of racism and extraction, we must strive for more equitable research practices. Her current projects explore communication about medical racism, shared trust between clinicians and patients, and the creation of community-driven, culturally responsive science communication strategies and messages. Dr. Williamson is going to be giving a talk on more than a moderator. That's the title of the talk, thinking more intentionally about medical mistrust. And this is a topic that a lot of us probably in Maryland were not super familiar with. So we're really grateful for Dr. Williamson to be here and give us an overview of this field in this really important research area. So Dr. Williamson, go ahead. If you can share your slide. Feel free to just give us maybe more information about you, your research as well. So I'm not sure my introduction's doing you any justice, but just go ahead.
No, thank you for having me. And the introduction works well, and that is sort of how I plan to start my talk. So goals for today are to tell you a little bit about who I am as a scholar and how I approach my work to define medical mistrust and put it into a bit of context, at least in terms of how I think about it. It really can be sort of an umbrella term. So I think it's important to specify, and so you know how I'm thinking about that term. I'm going to talk a bit about some of my work that I think provides some evidence about why we should broaden our view of medical mistrust, what contributes to it, what it might look like, and why I think we should be intentional about thinking about medical mistrust. I'm not going to go into a ton of super specific details about studies. I'm really hoping to have a broader conversation about medical mistrust, but I'm happy to go into detail during Q&A if you have questions about specific studies. And then I'll wrap up talking a bit about where I think communication scholars specifically might go next in this space, because I do think that thinking about medical mistrust is sort of on the agenda and should be on the agenda for health communication scholars. So in terms of who I am, I'm very much probably what you would think of as a topical scholar. I've very much been focused on medical mistrust and increasingly relatedly, some thoughts about trust in medical and science spaces. In a bit, you'll see why I have that distinction drawn here. And as part of that, I have been thinking about shared trust. Some colleagues and I have started advocating and talking more about this idea of shared trust. I think we often hear about trust, if you think about clinical spaces, to the extent in which patients trust clinicians. Do potential research participants, do they trust the research team or the clinical coordinator that's inviting them to partake in the study? But if we think about it, trust is really relational. It's the outcome of sort of relational dynamics, and it's bidirectional. And so we also can't forget the extent to which clinicians trust their patients. As researchers, do we trust our participants? I think in both ends, sometimes some of our training almost inherently puts us in a position to be suspicious of our patients or our research participants. And so thinking about that bidirectionally. A large chunk of why I have looked at medical mistrust is because of its intersection with communication and inequalities. And increasingly, I'm also thinking about how all of these ideas are related to and intersect with ideas around community engaged and inclusive research. So as I said, I want to sort of provide some clarity about what I mean when I'm using the word medical mistrust. Medical mistrust in some ways is an umbrella term. We could be talking about perceptions of one's own physician, about hospitals generally, about doctors generally. Sometimes you see work that is labeled as medical mistrust, and they're talking about interactions or perceptions of pharmaceutical companies. So it is sort of this large overarching term that actually can encapsulate lots of objects of that mistrust. Additionally, scholars have sort of used two primary ways of defining or thinking about medical mistrust. One is that mistrust is low levels of trust, or that it's the absence of trust. I, however, am in a camp of scholars that think about medical mistrust as more than the absence of trust. It's not just the opposite of trust. That medical mistrust is really about suspicions or concerns about the motives of medical personnel and institutions. So beliefs that medical personnel or institutions don't have patients' best interests at heart, or might even actively work against those best interests. I think making that distinction does two things, and thinking about mistrust in this way does two things. One is that it's then possible to have low levels of trust without actually being mistrustful. So for instance, if I go to a medical appointment and the clinician walks in and I think they look really young, maybe I'm concerned that they haven't had enough training or experience to diagnose me or treat me, I might not trust them. I might think my needs might not be met, but that doesn't mean that I'm concerned that they're actively working against my best interests. The other reason I think thinking about mistrust as suspicions about motives is that it becomes important when we're thinking about persistently marginalized communities like Black communities, because then it does situate medical mistrust as an outcome of experiences related to racism, discrimination, oppression. And I also want to give the caveat that I am often thinking about medical mistrust along the lines of race and in the context of Black Americans. But as you'll see, many of the things that I'll talk about today likely have at least some level of application sort of across persistently marginalized groups. So I make this distinction between mistrust and trust, but I know sometimes people wonder, does that really matter? Are there really differences between trust and mistrust and how we think about them? And we do have some evidence, at least, that trust and mistrust can result in differing associations with some of the variables we might be interested in. So we can't necessarily assume that a body of literature that we have on trust or the ways we're thinking about trust automatically apply or are relevant to mistrust. So in January of 2021, with a grad student here at UW-Madison School of Pharmacy, we did a cross-sectional survey to look at the relationships between trust and mistrust and their relationships with vaccine necessity, vaccine concerns, and vaccine intentions in the context of COVID-19. And this was based on some work that had been done in the context of HIV antiretroviral therapy, where they found that trust in providers, for instance, could ameliorate medication concerns. And so we were curious, what does this look like in the context of COVID? Does individuals trust in providers? Could that actually mitigate or ameliorate vaccine concerns? And we found that it didn't. Trust in providers and trust in information was related to vaccine necessity. So the more trust they had, the more individuals perceived the vaccine to be necessary. But there was absolutely no relationship to vaccine concerns. And for mistrust, we saw sort of the opposite pattern. No relationship to vaccine necessity, but there is a relationship to vaccine concerns. So we see slightly different patterns. I think part of it is COVID-19 is novel, the type of relationship you potentially have with a provider when you're talking about HIV medication. But I think the larger point is that we when we think about trust and mistrust, it might not be enough to just measure one depending on what we're interested in, because they do seem to have these differing relationships with outcomes of interest. So as you can imagine, medical mistrust, why are we concerned about it? It impacts an array of health and health-related behaviors. You've probably heard of it over the last, what are we at now? Now 4 years in the context of COVID-19, because it does tend to have a negative relationship with vaccination. But really, medical mistrust is associated with health behaviors sort of across what I think of as the healthcare continuum, from preventive measures, willingness to get routine checkups, cholesterol screenings, decreased likelihood to be screened for things like cancer, decreased likelihood for treatment adherence. It's also associated with lower likelihood of becoming an organ donor, engaging in a clinical trial. So it really sort of cuts across a lot of domains. But it also can influence perceptions of the provider's communication, as well as there's evidence that individuals who have higher levels of medical mistrust are less satisfied with their clinical interactions. And we know that satisfaction with the interaction is related to treatment adherence. As you can imagine, if you go to a doctor's appointment and you are mistrustful of the clinician, you're going to be dissatisfied. And if you're dissatisfied with the interaction, you're unlikely to follow through with the treatment plan that particular clinician discussed with you. And so because groups that have been historically and persistently marginalized, especially we have a lot of data when it comes to racial ethnic groups, have higher levels of medical mistrust, this can lead to a decreased likelihood of engaging in these positive health behaviors that we typically think of as wanting populations and individuals to be engaging in. And as a result, medical mistrust winds up being one of a multitude of factors thought to contribute to some of the differences that we see in health outcomes. And it's one of the reasons I became so interested in medical mistrust, is because it has this relationship to health disparities and cuts across so many sort of contexts and domains. So because of that, I think it's worthy of attention in and of itself as a concept and as a construct. But if you take a look at the medical mistrust literature, even across disciplines, we know a lot about the health behaviors and health outcomes that medical mistrust can influence. We've looked at medical mistrust as a moderator, particularly in communication. When I first started doing this work, I had scholars tell me they couldn't imagine whole papers on medical mistrust because they only ever threw it in their models as something they knew that they should account for, but they weren't thinking about it in and of itself. We, I think, have still only potentially begun to scratch the surface on the types of health and risk-related relationships that medical mistrust moderates and influences. And we've done much less thinking about medical mistrust as an outcome. And so as a result, what contributes to medical mistrust and the nuances of medical mistrust itself has been more of a black box compared to the plethora of literature that we have in terms of medical mistrust and its association with health outcomes. And so for me, thinking about antecedents of medical mistrust, thinking about medical mistrust in and of itself should be on the agenda for health communication work. At the end of the day, medical mistrust is really an attitude that results from the messages that we get about healthcare providers and the healthcare system, and that puts it squarely in health communication territory. So my pathway to medical mistrust actually started in the context of organ donation, and it's sort of starting in the beginning to give sort of context to what we and I now know about medical mistrust. But I also share this in case there are early career grad students in the audience, because for me, this was something that my path to medical mistrust was fated or accidental, depending on how you want to look at it. This came out of work that I wouldn't have anticipated doing. And so I do think it's a testament to taking the opportunities that come your way as a graduate student. You never know what experiences you might get in terms of methodology or content, or it might just give you a different way of looking at the world. And so my master's advisor called me into his office. I was taking his health campaigns class. He called me into his office after class Instead, he'd been asked to run focus groups in Chicago with African Americans to understand their organ donation beliefs. And he felt like he shouldn't be the one to run those groups because he was a white male, and he felt like he shouldn't be the one to step into that space. And he asked me, was I interested? He said he saw how I handled Q&A when my group presented that day, and that he thought I could actually do fairly well moderating a focus group, and asked me if I was interested. So at the time, I knew nothing about organ donation. I had to learn what it meant to moderate a focus group, but because I took that chance, it sort of took me on this path. So you never know how the ways you engage in your courses with your faculty members might open doors, and you never know what opportunities to learn sort of change your research trajectory. So for this particular study, we were using the health belief model to think about African Americans' organ donation beliefs broadly. So thinking about severity, susceptibility, benefits, barriers, self-efficacy, cues to action. But what stuck out to me is how often medical mistrust came up as a significant barrier, and it was coming up differently than the way it was being discussed in the organ donation literature. So at the time, the organ donation literature was very much talking about medical mistrust as being centered on ideas around premature declaration of death. The concern that if you showed up in the ER and they knew you were an organ donor, they wouldn't work as hard to save your life, which is not what takes place. And the team that's saving your life isn't who, if things went poorly, would not be who would find out if you're even an organ donor. But that misconception is something that often comes up, and is how the organ donation literature was talking about mistrust. But our participants weren't fully always talking about that. There was a little bit of that, but there were other things that to me were more interesting. So they were making connections, for instance, between police violence that was happening. And for context, these focus groups took place in the summer of 2015. So this would have been the same summer that Freddie Gray was killed in Baltimore. This would have been the year after Tamir Rice in Ohio and Michael Brown in Missouri. So it was salient, but they were making connections between wrongs in other institutions and systems and what that meant for their mistrust, not only of that system, but of the medical system as well. So they were making connections across systems. And for a while, there have been at times discourse or sort of an undercurrent that suggests communities of color who are mistrustful don't know better, or are paranoid, or are misinformed. And in some ways, I think our participants recognized that. They were talking about the fact that they weren't ignorantly skeptical, that it was based and rooted in information. Here, participants talking about not only the Tuskegee experiment, but what happened in Guatemala. She really wanted to emphasize that these things and the reasons we're mistrustful are rooted in real events, real experiences. And so there was so much discussion of medical mistrust that happened organically that I was really interested and really wanted to take a closer look at just the discussions of medical mistrust. And so we did a secondary analysis of only the discussions of medical mistrust. And we found sort of two things. One, we were thinking about, is there a way to think about and organize how medical mistrust is being discussed and the types of medical mistrust beliefs that were coming up? And what we found is that they were sort of level, and I always think of these as sort of concentric circles, that some of the things were specific to the context in organ donation. So some of the things were about premature declaration of death, but that is situated in mistrust of medical institutions, where you would hear things like the U.S. Public Health Service syphilis study, commonly referred to as the Tuskegee study, or things about Henrietta Lacks, or issues in the medical system itself. But even that was couched in mistrust of general institutions, both the government as well as other institutions. And even then, all of that for participants was couched in what it meant to be Black in the US. There were comments about, well, I'm mistrustful just walking outside my door because of how this country has treated Black folks. And so we saw this in the context of organ donation, and in some ways, I think the three outer levels can apply to many things, and that the innermost circle is just context specific. We could swap that out, and I think it would apply, for instance, for COVID-19. There were things that were specific, for instance, to the vaccine. There were concerns about the perceived speed at which the vaccine came about, but those concerns were couched in these sort of broader levels as well. The other thing we were thinking about was sort of the role of communication and what were people pointing to as having contributed to their mistrust beliefs. And we did hear some things about interpersonal communication in terms of hearing experiences of family members when they had loved ones die, either specific to organ donation or just more broadly in terms of experiences with the healthcare system. But there was also discussion of racial discrimination and in news stories. And at the time, there was not a lot of discussion about organ donation and news. At the time, that field had shifted away from it slightly. There was sort of more emphasis on entertainment media. What happens when you watch Grey's Anatomy and how that might influence your organ donation beliefs and medical mistrust beliefs. But here, participants kept referring to what they were terming sort of true information sources and news stories, and they recounted a story of a Latina woman who was in need of a kidney. Her brother was a match, but he was going to be deported and not allowed to stay in the US. And that was pointed to as an example of, see, the rules are different for people of color in this country. When it's us, we don't get treated the same. These sorts of things happen. And I did. I went back to see if I could find the news stories, because I felt like some of the same people who might attribute communities of color mistrust to paranoia or ignorance would claim, well, they're mixing up stories or misremembering. And so I wanted to see if I could find the stories, and I could. The story had run that April in Chicago News Stories, and this was the exact story that was coming up when we were asking about organ donation and they were discussing mistrust. So at this point, it seems like there is something about racial discrimination news stories, which was really interesting to me. And this idea that racial discrimination experiences potentially even outside of the organ donation context and the healthcare context could influence medical mistrust. And so the next thing I wanted to know was whether or not these relationships extended beyond organ donation. So based on priming and social cognitive theory, we were trying to figure out if individuals' knowledge of other people's racial discrimination experiences was related to medical mistrust, so having heard stories or having been told, and experimentally test whether there was an impact of mediated racial discrimination experiences, so news stories about racial discrimination, whether that influenced medical mistrust. The sort of correlation between others' racial discrimination experiences and medical mistrust existed. And then we also did the experimental manipulation. So participants were randomized into one of 4 conditions. They were either exposed to an explicit racial discrimination story that was manipulated through a racialized location. It explicitly said that the group facing the discrimination was Black. There was an implicit racial discrimination story that was manipulated along the lines in the way it's done in psychology, so through a racialized location in a class queue. And then there was a non-discrimination story, or folks saw no story at all. And we actually did it across 4 topics, 3 of which were non-health related. So stories were about lead poisoning, zero tolerance policies in school, voter ID laws, or policing for profit. And what we found is that for Black participants, there was a difference between implicit racial discrimination news stories and the control non-discrimination story. And we suspect that part of this, when we looked at some of the other items and things we did to sort of check that the manipulation was salient, folks didn't really see a ton of difference between the control and the explicit. There was no significant difference between those 2, which makes us think that folks tend to think of the baseline as there being discrimination, and that it's when it's hidden, that because the implicit was a situation where racism was clearly at play, but it was not being acknowledged, that it was the hidden nature that made the implicit racial discrimination condition, exposure to those news stories is what increased medical mistrust above the control. So at this point, I know, okay, medical mistrust seems to be broader and more nuanced than at least segments of health communication are treating it. The news stories and racial discrimination news stories, even outside the health realm, are being brought up. I now have some experimental evidence that this extends beyond organ donation. There's not just something special about organ donation, and that's why those relationships were showing up. And so I started thinking about, okay, is there a way to think about the ways in which what I termed vicarious experiences, so hearing about these negative either healthcare experiences or racial discrimination experiences through others, so interpersonally or through media, and how that might relate to medical mistrust, and started trying to organize some of the things I had seen and starting to think about the pathways and routes to mistrust as an outcome. And I was curious about whether or not these routes might differ for Black and white Americans. And so this data was collected in 2019, so it is pre-pandemic. Like every couple of weeks, I have a thought and have questions about the extent to which this still holds and how much things have changed since 2019. But I did cross-sectional survey to try to think about some of these relationships, and ultimately part of the reason I formulated it this way is sort of reimagining and reorganizing Street's ecological model of communication and medical encounters and thinking about what that might mean for mistrust. Okay, this model is busy, but there are a couple of big picture things that I want you to take away, and I'm going to sort of dissect it a little bit. One is the model did fit the data, and there were some things that applied for both Black and white participants, some things only held for Black participants, and some things only held for white participants. So for both Black and white participants, there were direct effects. So negative healthcare experiences that were personally experienced, as well as racial discrimination experiences that people were exposed through media, had direct relationships with medical mistrust. There are also indirect effects for both of the media variables. So when the more frequently you were exposed to negative healthcare experiences or racial discrimination experiences through media, it had influences on medical mistrust, but in slightly different ways. When it was a negative healthcare experience through media, that decreased perceptions of perceived financial corruption in healthcare, whereas racial discrimination experiences in media increase perceptions of perceived financial corruption in healthcare. At the time, perceived financial corruption in healthcare hadn't actually been quantitatively tested as part of this pathway or as a mediator to medical mistrust. So we do know that that is part of what's happening and part of the things people are thinking about. And for the sake of time, I won't go down too many rabbit holes, but if you're curious, I can certainly talk about why I think there are differences between negative healthcare experiences versus racial discrimination experiences and effects on perceived financial corruption. For Black participants, when it came to racial discrimination experiences that they were exposed to through media, increased frequency not only increased perceptions of financial corruption, but perceptions of perceived racism, which did not occur for white participants. And then for white participants, both of the interpersonal variables increase their perceptions of perceived racism. So the more they heard about others' negative healthcare experiences, the more they heard about others' racial discrimination experiences, the more they perceived racism in healthcare. But if they more frequently reported having experienced racial discrimination experiences themselves, that decrease their perceptions of perceived racism in healthcare. This is likely because that perceived racism in healthcare measure is framed as perceived racism against Black Americans. And so it seems as though when they were experiencing it themselves, they were sort of thinking of it as a zero sum. Instead of thinking, if I'm experiencing this, maybe it's even worse for Black Americans. It seems like they were thinking, I'm experiencing this, and so it must not be happening, or it's happening less for Black Americans. And then for white participants, we also see this association with income. So higher income meant higher levels of medical mistrust. So one of the things I think is when we take this sort of systematic approach and starting to look at things, we find that medical mistrust is kind of complex. It can be tied to institutions outside of medicine. We have interpersonal and mediated communication playing roles. And we can think about it at different levels. Hiding the role of racism might increase medical mistrust. There seems to be potentially a variety of experiences that could contribute. By no means do I think that negative healthcare experiences and racial discrimination experiences are the only types of experiences that likely contribute to medical mistrust. And there's no single pathway to mistrust, and that matters. It means that we need to understand the underlying beliefs if we're going to discuss or address medical mistrust. So for instance, if we're going to create a message, or if a clinician is going to try to talk to a patient about medical mistrust, the underlying beliefs and the pathway they took to get there matters. If I'm trying to talk to a patient about alleviating concerns about policies that are in place so that the medical system doesn't have disparate outcomes along the lines of race, or if I'm talking about it assuming that the patient is mistrustful because of perceived racism, but really they're concerned about financial corruption, that's not going to work. So we really do need to understand the underlying beliefs. And so ultimately, there's some sort of big facets in terms of what I think medical mistrust being complex means. One is, I think often we connect it to the US Public Health Service syphilis study. You've probably heard it referred to as the Tuskegee study. I always say the mouthful, and I actually would encourage all of you to say the mouthful instead of the shortcut Tuskegee syphilis study, because as communicators, we know that how we label things is really important. It has consequences for how we think about those things, for what we think the solutions are. And when we only refer to it as the Tuskegee syphilis study, the US Public Health Service, who caused the harm, gets omitted from that. I recognize that not everyone might actually be familiar with the Tuskegee syphilis study. And so US Public Health Service withheld treatment from African Americans with syphilis and watched the progression of the disease. They did not tell the men that they had syphilis in order to watch the disease progress. Left untreated, syphilis can have dire consequences even after penicillin was a known cure. So this started in 1930s, 1940s. It didn't end till the 1970s. So even after penicillin was a known cure, they still did not treat the men for syphilis. And it wasn't a secret. The medical establishment knew it was happening. There were papers being written and presented at medical conferences. But we often hear and see medical mistrust being linked to that particular event. Occasionally, we might hear about Henrietta Lacks, whose cervical cells, without her consent and knowledge, were taken and used to create immortal cell lines known as HeLa cells. But it's really often the US Public Health Service syphilis experiment that gets brought up. And it's very much a salient example, but many of us would argue that it's really being used as an exemplar and as a stand-in for a broader array of things, because that event is one of a plethora of historical events. There's some examples here just to show that there are more examples, but by no means is this intended to be an exhaustive list. But physicians certified the fitness of enslaved people. They were on ships with kidnapped Africans in an attempt to keep them alive and quote unquote healthy. The sort of father of gynecology, J. Marion Sims, who up until, I don't know, maybe 5 to 10 years ago now, had a statue in New York, maybe in Central Park, and is sort of hailed as the father of gynecology. But he perfected those techniques on unanesthetized enslaved Black women. We've had eugenics and forced sterilizations in this country for Black, Latina, and Indigenous women. California and North Carolina had 2 of the biggest programs. There have been radiation experiments that were funded in part by an agency that was with the Department of Defense that was conducted in Cincinnati General Hospital. in the 60s and early 70s, and those experiments were disproportionately comprised of African Americans. So there's really a constellation and a long history of things. If you're interested, I would suggest, if you haven't already, reading medical ethicist Harriet Washington's Medical Apartheid. She sort of chronicles these events from times of enslavement to present day, and many of the sort of contentious and harmful relationships and things that have happened between medical system, medical establishment, and Black Americans specifically. All that being said, we also have to remember that the things that influence medical mistrust aren't confined to history. I think sometimes the discussion of U.S. Public Health Service syphilis study makes it seem like it was something that is in the past, that was then, there was a lot of wrong that was conducted then, but we've come so far. And so you should no longer, those things, the things that were at play then aren't at play now. You shouldn't be mistrustful, but we know that patients continue to deal with negative healthcare experiences. There's discrimination based on gender, sexual orientation, weight, disability. I have some descriptive data from a survey of sort of general population that suggests discrimination based on ability to pay might be of particular importance for medical mistrust if you look at sort of US population generally. We have recent data that not only the public, but medical residents endorsed the belief that Black people had thicker skin than white people. So all of these things still are at play, both sort of the legacies of things that have happened historically, as well as the things that we're dealing with in present day. So we also have to be careful to not position this as something that's only tied to historical events. It's impacted by the things that happen outside the doctor's office, not only my work, but other work has seen these connections. And it's because issues within other systems serve as reminders to groups who've been discriminated against, oppressed, intentionally marginalized. These systems were not meant for their well-being, protection, and might harm them. And I think that's why we see spillover, because it's just, here's another institution sort of showing that they might harm my community. And the other big thing is that it extends beyond personal experiences. It's not just what I experience that's going to influence my levels of medical mistrust, but it's also going to be what I read, what I hear about, what stories I'm told through family, what I see when I scroll through social media. And so we have to think about the effects of communication, that communication and the messages plays a role in all this. And I think we need to think more broadly and holistically about medical mistrust and recognize that it is a protective and adaptive response. So I think, with all that being said, I think there are lots of places that communication scholars can step in, because we have so, comparatively, there's much less work thinking about medical mistrust in and of itself. And so I think there are a lot of spaces where we could make progress. So thinking about what are the other messages that contribute to medical mistrust, and under what circumstances, what are the bounds, what does this look like? We know that it seems like if racism is clearly at play, but hidden, that could increase medical mistrust. I have some work that explicit racial discrimination in news stories can influence medical mistrust, but only when it's specifically health related. Working on some data now that's thinking about the role of anticipated discrimination and the ways in which that influences how people are perceiving these messages, and thus having sort of changes in attitudes that we see in medical mistrust. What other outcomes and processes does medical mistrust impact? I have some work not just thinking about things like whether or not you go to the doctor or get a cancer screening, but even information seeking. And we know there's some relationships between medical mistrust and misinformation, where people might seek information. Thinking about when changes are made, how do we communicate those changes? So if you're thinking about medical mistrust as the outcome of things like medical racism, issues in the healthcare system, issues in systems, when organizations, when institutions do attempt to enact policies or steps are taken to deal with those things, how does that get communicated, and how do we do that effectively? Thinking about how the media and the public talk about mistrust and related events and the effects that might have. So for instance, the fact that US public health syphilis study does get so much attention, does that make the public think about that as something that is in the past, and thus makes it harder to have policy support for things that would rectify some of these things. And also thinking about what does it look like to integrate medical mistrust. I see it as something that's adaptive. I actually think it's harmful to try to convince communities or individuals to not be mistrustful of systems and institutions that have shown that they do and can harm them. But I do think it's possible to allow people to hold their mistrust and integrate it into their decision making. We know folks did it in the context of COVID-19. For instance, there were plenty of Black Americans who were mistrustful, but still got the vaccine to protect themselves, their family, their community. So they did hold that, but clearly weighed it against other things and still decided to get vaccinated. So I'm going to spend my last bit of time briefly talking about some of the things I'm thinking about now when it comes to when changes are made or when policies are enacted, or what does it look like as we try to change things. One of the things I've been thinking about is what might it look like to acknowledge things like medical racism. Is there a way to do that effectively in a way that does not seem like you are pandering to a particular community? It could be seen as manipulative, like you don't, it could be seen as disingenuous, as though you don't really mean it, but you're trying to get a community to do something like get vaccinated. So colleagues at UT Austin and I did a little bit of this just by adding this very short blurb at the bottom saying that concerns are valid, especially for Black Americans who've long been mistreated by the medical system, and thinking about, does this have any effect? What we found is not really. I think at this point, what we know is that acknowledging may not always help, but it probably won't harm. So we know that if it's at play and you don't acknowledge it, there's some experimental work that suggests that could increase medical mistrust. But here, this acknowledgement didn't increase mistrust. It didn't invoke counter-arguing. It didn't come across as manipulative. It didn't result in message derogation. Many of the things that we're often potentially concerned about a message doing, it didn't do any of those things, but it also didn't shift how people were thinking about the vaccine itself. So it doesn't seem like it necessarily helped, but it won't harm, and that other scholars who are physicians and public health folks who have tried to also do this acknowledgement have sort of seen the same thing, where they didn't see negative influences of the acknowledgement, but it didn't necessarily bolster knowledge or engagement or any of those things. And so one of the things grad students and I are currently thinking about is there a way to think about apology frameworks and thinking about how to best acknowledge medical racism? Most of the literature that thinks about apology as a speech act, apology on an interpersonal level, talks about apologies having these components. And so we were wondering, is it possible that one of the reasons some of these things haven't had much effect is because it only had one of these components, or did this component in a particular way? And a lot of that work talks about remorse, or at least recognition of wrongdoing, responsibility, an offer of repair, and then forbearance. So saying that you won't do it again. And so the acknowledgement piece is at least probably recognition and responsibility. We took a look to see if anyone was already trying to test some acknowledgement messages. And we looked at those. We saw that some of those things had flavors of the pieces that we see in the apology frameworks. And so now we're trying to test and thinking about the extent to which acknowledgement and or repair, with all messages sort of speaking to responsibility and forbearance, if that can have an impact on things like credibility and perceptions of the message and the source. So I want to end with saying that sometimes we think about mistrust and the things that impact it is outside ourselves, but as individuals tied to institutions and entities, and often wanting to impact health outcomes for communities, engage with communities, I think we also have a duty of care towards ensuring that the ways we engage in research don't contribute to mistrust. And that requires investment and engagement. For those of us who are trying to work directly alongside community, that means showing up long before the crisis arrives. It takes true engagement, and building relationships is important. Collaborators at the Medical College of Georgia, which I'll talk about briefly in a moment, did interviews, and we were looking at community trust and what folks who lived around the medical college, what they wanted to see and how they thought of MCG as trustworthy. And one of the things that stood out to me was a community resident talking about the extent to which medical students and residents would park outside his house and never acknowledge him. He would be sitting on his porch and they would just ignore him. They wouldn't speak back to him. They wouldn't wave. They wouldn't say hi, but they were parking right in front of his house, but never acknowledging his existence. But if he showed up in the clinic, those same people would expect him to trust them and to engage with him. And he's sort of like, if you didn't engage with me and you didn't recognize or acknowledge me outside of this space, why would you think that I think it magically changes once I'm in this space? And so thinking about how we build relationships is important. And I think part of that is transparency. And the other part of that is thinking about community members, about patients as sort of shared power, and thinking about them in a way that makes them equal partners in whatever endeavors we're pursuing. And so as part of that, my collaborators at Medical College of Georgia developed CRANE, which is funded by Patient-Centered Outcomes Research Institute, PCORI, for a capacity building award. And what they do is CRANE is comprised of a network of community members, and the model focuses on engaging those community members and those groups as co-researchers. So they have an active role, they enact control throughout the course of the research, and there's sort of a collaborative and interdependent relationship with the research team. So there's truly shared leadership, and it's really the community members who point to and decide on community concerns. They're who develop the research questions. They generate community solutions, and the research team helps facilitate that. And it's done things like the research team was thinking about health outcomes and the ways in which those have cropped up in the Augusta community. And the community members were concerned about things further upstream that caused stressors that led to some of these health outcomes. So they were concerned about mental health, about housing insecurity, about gun violence, and those are the things that they wanted to tackle. But without sort of the shared leadership and allowing the co-researchers to direct some of that research team, we would have been thinking about things that aren't actually what the community needed. And then I'm also very fortunate to be working with colleagues here at UW-Madison in life sciences communication, as well as Ubuntu in Milwaukee. They're a research and evaluation community organization on a project examining an equity-based science mistrust and misinformation. And part of that work is investigating whether the underlying beliefs and pathways and things we think about for medical mistrust exist for science mistrust, because medicine is an application of science. And so to what extent are the things that we see for medical mistrust also applicable to science more broadly? And the intention of the project is really to engage in dialogue with community. So we've started with community conversations, and we shared what we found through that with community and had conversations. We're in the midst of focus groups. We'll then do surveys, return to community, then we'll do some experiments and return to community again. And so the sort of design of the mixed method project is to truly engage in dialogue and center community and allow them to shape and drive the sort of things that we're looking at and where we are devoting interest. And so we're super excited about the project. We do have a project website. This QR code will take you there. We have reports up from the first round of community conversations. We're currently working on the papers for academic audiences, but we have the site set up for folks who are just interested in the process and what we're doing to sort of keep track of that. So takeaways. for me, I hope what you took out of this is that medical mistrust is far more complex than we often discuss it. It's worthy of attention in and of itself, not just something to be thrown into a model because we know we need to account for it. It truly can be important. It's impacted by and influences things in and outside of the clinical encounter. I think sometimes when we hear the term medical mistrust, we're only thinking about what happens between a clinician and a patient, and it's wider than that. And there's still a great deal to be done, and I think communication scholars can play a pivotal role in that. So thank you for letting me talk about medical mistrust. Feel free to email me if you have questions. I'm excited to chat. I also put a QR code that goes to my personal website. What I try to do is for any paper that I have the copyright agreement for, and I know very clearly what I can post. Like I put the accepted manuscript with link, or if it's a open access, the link takes you straight to the paper. So if you're interested in any of the particular works, you can find it there. So I will stop there, and I'm happy to answer questions.
Wow, thank you, Lily. That was fantastic. I really love the clarity that you presented this topic that we haven't really thought too much, at least in my work, but I done some work on trust, medical trust and vaccination, and the relationship is like is as clear as the daylight. You know, I mean, it's just I've never seen like a strong relationship like that in social science. So yeah, we got a bunch. I think about got a bunch of questions or maybe comments. Irina, do you have a question? Maybe you can ask Lily directly, or is that a comment?
Of course, I can ask it directly. Can you all hear me okay?
Yes.
Yes.
Terrific presentation. I'm Irina Isles. I used to be at the University of Maryland. Dr. Nunn was my advisor. I am now a program director at the National Cancer Institute. And my colleagues and I have a great interest in studying trust at the medical level, in general, in public health, in science, etc. And I was really fascinated by your distinction between trust and mistrust, and how mistrust doesn't just mean low trust or lack of trust. And I was wondering if you happen to know the correlation between the two, and if you could give me an example of an item used to measure medical mistrust. There are a variety. I think an issue with, the trust literature is that there are a variety of scales that can be used that are or are not used depending on the study, especially in nationally representative surveys that are conducted over time. So I think there's a lot of work there to be done as well, but I would be really interested in this information to contextualize your presentation a little bit better in my mind. Thank you.
Yeah, thanks for the question. I don't know off the top of my head, but I know I have run the correlation. It's not super high. They are correlated. I think they're related. Like I think that building trust can help offset some mistrust. So I think they're distinct but related. The items question is hard to answer because like trust, people have used tons of different scales. The two most widely used are the Medical Mistrust Index by Levice and then the group-based Medical Mistrust Scale, which is Thompson. And so they take slightly different approaches. I can pull up items now. I will also say that I can also, if you're interested, I can send you, I did a systematic review on measures of medical mistrust and tried to categorize them. And so we know by object and by even, are you asking about, am I mistrustful? Do I think people like me are mistrustful? There's all these different permutations and formulations. And I think at the end of that paper, we tried to actually give a decision tree, like what things do you care about? And if you're concerned or thinking about group identity as playing a role, use this scale, versus if you're concerned about healthcare organizations or these other things, use some other scales. But broadly, like some of the items are super explicit, like patients have been misled or deceived by healthcare providers. healthcare providers will use patients as, or I'm trying to think, the group-based scale, I think the wording is people of my race, ethnicity should be concerned about being used as guinea pigs in research. Yes. And so like the medical mistrust index is more what I consider general medical mistrust. And so it doesn't add the element of race or a group. And then the group-based does have that element. Does that help some? I can pull up more explicit wording, but off the top of my head, those are the flavors.
It definitely does, quite different from what we use to measure trust, and it makes a lot of sense. I will message you my email address. I would really appreciate whenever you have the time, if you could share the resource you mentioned with me, the systematic lit review. Thank you so much. Again, really, really great presentation.
Yeah, happy to
it's
share it.
wonderful. Thank you, Irina. I just want to say you stole my question, two of them. Do you guys, others have any other questions for Dr. Williamson? We're approaching the 2:45, but I do have Lillie, let's think about this. I know you probably don't have access to all the specific items. In your view, do you see how do you conceptualize medical distrust? Like, do you see that as more of a multi-dimensional kind of construct, or unidimensional, like on a conceptual level? Like, you're obviously an expert on this. What is your 3,000 feet overview
Ooh.
of this concept?
Oh man. Okay. That Charlie, I feel like that's such a loaded question. Okay, I think I'm still trying to wrap my head around it. Like distinctions between trust and then mistrust slash distrust are clearer. The mistrust versus distrust gets muddier, and I think it also depends on who you ask. Like philosophers think about it as like mistrust is misplaced trust. So there had to have been an event, and then I now know that that was misplaced trust. So now I'm mistrustful, versus I see distrust as a there's nothing happened, but I'm forward thinking and anticipating something having happened. There's some public health scholars who try to make a distinction about mistrust being a more general feeling, and distrust being tied to explicit events. But even then, that distinction I have questions about, because they put the U.S. Public Health Service syphilis study as contributing to their mistrust and like generalized feeling. And I was like, but that's still a specific event that someone can point to. It may not have happened to them. So like trying to disentangle the like vicarious nature, what has to have happened to me versus I just know about, and how that gets integrated. I'm still trying to think about how we quite disentangle mistrust and distrust. And then I also have questions about, I come back to, would that distinction matter? Because most of the distinctions seem to be about where the origins came from, or has something happened or not. And like, I'm not sure if then if we think about mistrust versus distrust and a health outcome, or where someone's seeking information, I can't tell if it's gonna make that big of a difference in terms of, does it matter how I arrived there? Does it just matter that now I have this general attitude and I'm there? Is that the only thing that matters? Or the extent to which the pathways, and if it was just my own experiences or projected. And so that was a long way to say, I'm not sure. I'm still trying to disentangle it, but it's a question that I am thinking about. I just don't know if I have a great answer yet.
Yeah, I mean, in the presentation, you said, medical mistrust is a complex phenomenon, complex concept. I think not only in terms of the antecedents, what's causing it, and the consequences, what it affects, but also itself. The concept itself is something of a mystery. Like, so many questions you asked about it. It just shows how complicated this is. All right, so thank you so much. We're way beyond time. Thank you so much, Lillie, for coming here today. I think this is really wonderful presentation. I love the clarity. I think Your research program is super focused. I think you're addressing a very, very important issue in health com in general. And glad to know that you are moving on to science com and looking at science mistrust. I think that's gonna be even more fascinating. So
Well, thank you so
yeah,
much
thank
for
you.
having me.
Yeah, thank you everyone for coming. I hope you guys all have a good weekend. We'll see you next time.